Hello and welcome to Myeloma 101. My name is Craig Hoffmeister from The Ohio State University, and these slides were sponsored in part by Multiple Myeloma Opportunities for Research and Education, for which Nancy Kaufman is president. Multiple myeloma presents at an average age of diagnosis of 70 years old. And most of the time it presents with fractures, anemia, and kidney failure. You can see in this pane in the left-hand side a cartoon of the lumbar spine, which, if infiltrated with multiple myeloma cells, causes the vertebra to crumble related to patient's flexion and extension as well as gravity. If you see this on the MRI, you can see this vertebral compression fracture here. If you were to stick a needle into this vertebral compression fracture, the cells inside that vertebra would look just like this, wall-to-wall myeloma cells. What's different about this patient is that he presented when he was 16 years old. Luckily, he was treated, underwent an autologous stem cell transplant, and is currently alive and well and in complete remission at 22. Multiple myeloma starts off as two precancerous conditions, MGUS and smoldering myeloma. MGUS stands for monoclonal gammopathy of undetermined significance, which occurs when a clone of plasma cells mutate, essentially to not die. These mutated plasma cells, the patient's immune system cannot kill. And over months and years, more and more of these mutated plasma cells grow until you have enough plasma cells that we call it smoldering myeloma. Now, these patients still have a precancerous condition. They have, by definition, no symptoms related to these conditions. But ultimately, if the patient lives long enough, one or a group of these mutated plasma cells further mutate to attack and to kill the patient. And the patient develops the so-called CRAB criteria, which are high calcium, kidney failure, anemia, and lytic bone disease, which means that they have holes in their bones where plasma cells have eaten away at the skeleton, and these bones are weak and cause fracture. And these patients have multiple myeloma. What's really happening in myeloma and our success in terms of treatment, I like to think of myeloma cells as little termites. And these termites eat away at the skeleton of our patients, which is like the frame of a house, and they weaken it. And our chemotherapy regimens are like termite killer sprays that we can spray on the affected wood of the house. But because we can't take out the affected wood, we never get at the myeloma stem cell, the queen termite deep within the wood that either is never exposed to, but more importantly, is probably not susceptible to the termite killer spray that we cover the patient's skeleton with. And so ultimately, the vast majority of patients with myeloma are not cured because we have not found effective ways to kill the myeloma stem cell. Now, it's not all bad. This study, published by Dr. Shajit Kumar at Mayo Clinic, this is a Kaplan-Meier curve, looking at percent of patients surviving on the vertical axis and how long they survive on the horizontal axis. And you can see the patients from 1971 to 2000 all essentially have the same overall survival. But this group in gold here from 2001 to 2006 lived longer. And in fact, the group from 2006 to 2010 lived even longer. And they lived longer because they had access to new therapies that were effective for their myeloma. In addition, we've had two new drugs recently approved. Carfilzomib or Kyprolis was approved in July of 2012, and pomalidomide or Pomalyst was approved in February 2013. Essentially, over an 8-month period, two new drugs were approved for an orphan disease. Scientists at the University of Pennsylvania reprogram patients' immune cells to attack patients with CLL, chronic lymphocytic leukemia, or ALL, acute lymphocytic leukemia. And we hope to do this in myeloma. And even though there are concerns about genetically modifying crops, we think that the ability to modify the immune cells of a patient and infuse them back in their bloodstream to attack a patient's myeloma cells could allow us to get rid of using poison to treat myeloma. And on the third row, the ENCODE project describes how huge achievements were made by opening up another 50% of the DNA for study. We used to believe that only 10% of our DNA was important and that 90% was just left over from human beings being around for millions of years. But in fact, 50% of the genetic code regulates this 10% that is active. And if you're trying to figure out how that could be important and how much regulation can really affect how different a living being could appear, think about a caterpillar and a butterfly. They both have the same DNA, but different parts of their genetic code are active at different times. Now, the standard treatment for a fit myeloma patient starts in general with 2 or 3 drugs. And we usually treat until the patient is essentially as good as they're going to get. Their fractures are healed, their kidneys are better, and they're no longer anemic. We usually do a drug, and they usually combine it with a steroid. The steroid that we use is dexamethasone. This is usually given as a pill, and it can cause insomnia and weight gain. Our patients hate steroids appropriately, and steroids are bad for almost every cell in your body, but they're particularly bad for myeloma cells. Revlimid is an immune modulating drug, an IMiD. This is a pill given usually 3 weeks on and 1 week off. And its notable side effects include diarrhea and the possibility of forming blood clots. Velcade is another treatment option for patients. This is a proteasome inhibitor, usually given like an insulin shot subcutaneously twice a week, and over time can cause tingling and numbness in your hands or feet. Oftentimes, Revlimid is combined with dexamethasone, Velcade is combined with dexamethasone, or Revlimid and Velcade are combined with dexamethasone. After patients are as good as they're going to get in terms of a plateau in their performance status, they often move on to receive high-dose intravenous melphalan, which is a drug that we dropped on the enemy in World War I, and we currently have rebottled it, and plasma cells, what do you know, are particularly susceptible to high-dose melphalan. It takes about 6 weeks to prep a patient and get their eligibility testing, mobilize their stem cells and freeze them in the bag, and then ultimately admit the patient to get high-dose IV melphalan. This can be done inpatient or outpatient. At our institution, it's done inpatient. Corresponds to about a 16-day hospital stay, and on average, patient's myeloma remains in remission for at least 30 months. Now, if you follow up that transplant in 3 to 6 months with a pill of Revlimid maintenance, this usually adds 18 months of remission to the patient's clinical course. A big question in treatment of myeloma is whether their disease is in control or out of control. If their myeloma is in control, they're not making new myeloma cells, their bones are not getting weaker, and they're not becoming more anemic. On the other hand, if their myeloma is out of control, if it's not getting treated, if it's resistant to a current therapy, there's more myeloma cells in the patient per minute. And essentially, I think of these patients who are not being treated or who are resistant to current treatment as almost in a free fall state. And our job is to catch you and treat you before you have worsening fractures, anemia, or kidney failure. So a newly diagnosed patient who is transplant ineligible needs treatment because their disease by definition is out of control. And without treatment, their survival is measured in months. Now the treatment options include drugs usually given in combination, Revlimid and dexamethasone, Velcade and dexamethasone, or option 3, Revlimid, Velcade and dexamethasone. These are certainly not the only options available, but these are 3 common options. At Ohio State, we often will use melphalan, prednisone, and Velcade as well for transplant ineligible patients, the so-called MPV regimen. So let's say this patient received Revlimid and dexamethasone, had a good response, and their disease stayed quiet for 24 months. But ultimately, their disease went out of control around 24 months of treatment. Well, the option at this point is to do Velcade and dexamethasone, Pomalyst and dexamethasone, or Revlimid, Velcade, and dexamethasone. After failing both Revlimid and dexamethasone and Velcade and dexamethasone, patients will have three options. They can have Pomalyst and dexamethasone, Kyprolis and dexamethasone, or Revlimid, Kyprolis, and dexamethasone are three common options. Ultimately, patients beginning fourth-line therapy after failing Revlimid and dexamethasone, Velcade and dexamethasone, and Pomalyst and dexamethasone, options could include Kyprolis and dexamethasone, Cytoxan, Kyprolis and dexamethasone, or Treanda, Velcade and dexamethasone. Understanding whether you have high and low risk disease is very helpful, because if you have high risk disease or low risk, your risk describes how quickly your disease will become resistant to treatment. Those who have low risk disease, it's easier to control their myeloma, they need fewer treatments, and these patients live longer. Patients with high risk disease are more likely to become quickly resistant to their current treatment, and they have a poorer overall survival. But understanding your risk is very complicated. Oftentimes, patients do not have their samples sent out, or the samples sent out are sent so far across the country that there are no myeloma cells actually in the samples. So the first test that's often done is a karyotype, where the aspirate samples are pulled out of the patient and left to grow on a dish. Now, this only actually occurs about 40% of the time because it's very difficult for myeloma cells to grow in a dish. But if you see an abnormal deletion of the long arm of chromosome 13, this is a high-risk feature. A more common test to assess risk is to do fluorescent in situ hybridization, which is staining a plasma cell just after it's been pulled out of a patient for certain DNA mutations or amplifications. We look for the deletion on the short arm of chromosome 1, the deletion on the short arm of chromosome 17 at the p53 gene, high-risk translocations, including translocations between chromosomes 14 and 20 and 14 and 16, as well as particular patients with translocations between chromosomes 4 and 14. We can also take myeloma aspirate samples and, through gene expression profiling, use and create a particular score for how high risk their plasma cells are. And there are companies that will do this. One of them creates a MyPRS score, and those with a score greater than 40 have high risk disease. If your FISH and karyotype for your myeloma were both normal, it's likely that there were inadequate samples to test, as virtually all patients have an abnormal FISH and/or karyotype.